I'll start, I guess. I'm a healthcare provider. I'm a family physician. I study this question, what do healthcare professionals need to know to be health literate communicators, or as I'll say, clear communicators in a world that requires better matching of information to skills. This is such a large question. I think the way we've thought about it is really as a deficits model, right? The state of our understanding right now is that we wouldn't be all in this room today if healthcare professionals were providing clear communication as the default, and the level and the degree to which health information is presented in such a complicated fashion and I'm talking about to everybody, not even specific to the populations that we're speaking about today. The gap is so large that you really have to think about this in terms of everything that healthcare professionals do, the way they do their work, and the way every message is crafted and presented. So there's not one quick answer, I think, to what needs to be done. I would say that the first thing is just getting our eyes opened, awareness raising specifically, and broad-based awareness raising across the country in all healthcare professions and in communities and advocacy communities. I think a very broad-based campaign to raise awareness of the real potential to improve lives through changes in communication is the place to start.
Are there other members of the panel who would like to comment on this question? The knowledge and skills that healthcare practitioners should have?
I mean, I can just comment broadly. I think, how many of you are familiar with the organization that I represent, just out of a show of hands? Okay, so let me just briefly say a little bit about the organization that I represent. So the Asian and Pacific Islander American Health Forum, we are a national health policy and advocacy nonprofit. We are based here in Oakland, California, with an office in Washington, D.C. And our role is to we work directly with community-based organizations all across the country, and we see ourselves as kind of an intermediary. So what we try to do is bring the experiences and voices that we hear from the community-based organizations to government, to the federal government, and engage in advocacy to kind of, address these issues that these communities are facing on the ground. So in the context of the Affordable Care Act, over the last 4 years, since the health insurance marketplaces first opened, we've really been bringing up the challenges, particularly in the Asian and Pacific Islander community, faced by limited English proficient and immigrant individuals trying to enroll in coverage. So that's kind of like the perspective that I'm speaking from. So I think, from the provider perspective, I think we've heard a lot of these concepts today about building trust, about working with community. And so I think, I think we'll talk about this a little bit later, but I'd like to talk about some models and ways that we can more integrate community-based organizations with providers in order to address a lot of these health literacy issues. So I think, I'll wait till some of the later questions, but that's kind of like the angle that I'm going to speak from.
Okay, any other?
Can I just add to that?
Yes, please.
Ian's comment about trust reminded me that Michael Villar earlier said that health literacy was almost the second step, and that trust and engagement were the first steps. And as you said that, I was thinking that really it's a very circular issue, and that health literacy really is the entree to trust and to engagement. And so I just wanted to come back to that. Thanks.
Okay, well, maybe we'll move on to the second question. And for those of you who haven't kind of talked about your organization, as you comment on this, if you could talk a little about it as well, because the first question was thinking maybe a little bit about what do people need to know, but the second question is what do we really need to think about from a systemic perspective, what are the systemic changes that are needed to improve communication around with immigrants, refugees, migrants, et cetera?
Okay. All right. Hi, everybody. I'm Tony Eiton from the California Endowment. I am a physician. I'm an internist, although I wouldn't be my patient if I had the choice. So I spend most of my time working on health policy and practice. And the California Endowment is kind of in the midst of a $1 billion initiative across the state in 14 low-income communities that are riddled with health disparities. And those communities are populated disproportionately by folks that are either fairly recent immigrants or refugees and or first or second generation populations. That's not the exclusive population, but that is probably about 87% of the roughly 1 million people that we're working with directly in our Building Healthy Communities initiative. And the goal of Building Healthy Communities is to, as I said, spend about $1 billion over 10 years in these 14 places to measurably move the needle on health status. And the big caveat for us, which is why I deferred on the first question, is that we're not investing a nickel in health care. So this is an entirely social determinants of health based initiative. And one of the things that strikes me as being pertinent to this particular inquiry about health literacy is, I mean, the context of the question assumes that the healthcare system needs people to be literate in order for the healthcare system to do what the healthcare system wants to do to people. And I think that question presumes a lot. We argue a little bit the opposite, which is that communities basically have a pretty good sense of what they need to be healthy, and they need the healthcare system and the education system and the criminal justice system and the land use system to essentially cooperate in facilitating their access to those health protective resources. So it's maybe some of these systems that are not as literate as they ought to be about the needs of populations. But with respect to the communities with whom we're working, there are strategies, we think, and it aligns with, and I missed most of the earlier presentations, but I heard some of the recap, which I thought was very helpful. It aligns with what was earlier referenced around trust, about building trust and this notion of agency, this both personal level agency and community level agency, so that people feel they have some control over the things that are happening to them in a day-to-day basis, because most of what we recognize as the root cause of chronic disease is this sense of allostasis or allostatic load, where people feel chronically stressed out and lacking control or lacking access to critical resources that they need to be able to pursue healthy lives. And so part of the way that we try to build a sense of trust and agency at both the individual and community level is to focus on essentially allowing people to tell their stories, the stories of how they got to where they are today, so that they not only are able to communicate their refugee story, their immigrant story, their historical story related to their ancestry, about their relationship to that place, but they're also able to hear the stories of others and hear the similarities and the experiences that people have in trying to navigate our very foreign environment. I mean, it's foreign even to many low-income people who've been here for multiple generations, trying to interact with some of these institutions that don't literally speak English. They use acronyms, and they have their preferred ways of communicating to people. They have eligibility criteria that you either meet or you don't meet, and if you don't meet, then you're basically turned away and told that you're not worthy or deserving or sick enough yet. So allowing people to see themselves as similarly situated with others who don't necessarily have the same ethnicity or language, but have a similar experience in trying to navigate this system, we think is particularly critical to facilitating a sense of belonging, that people belong in these places, that they're valued, that their perspectives and experiences matter. And we're trying to help some of the institutions that we work with in our places to kind of appreciate that aspect of storytelling as a way of facilitating trust between institutions and populations. So I'll leave it at that.
Mr. Morales, let's hear from you. Tell us a little bit about your organization.
Well, first of all, Tony pays, I think, most of my salary, so I'll have to full disclosure here, Tony. We are a grantee of the California Endowment. So I'm Hugo Morales. I'm the co-founder and director of Radio Bilingüe. And Radio Bilingüe is a nonprofit community radio network, and we own and operate 12 full power FMs, half of them here in California, and then the other half in states like Arizona, New Mexico, Colorado, and South Texas. And so we're building, we have established full power FM stations in very low-income communities and all along the U.S.-Mexican border, which is very relevant to this conversation. So I'm an immigrant myself. I'm an Indian, Mexican, Indian, Mixteco from Oaxaca, Mexico. So I came here when I was 9. And since you are all doctors, I can also full disclosure. I had tuberculosis when I was 12. Lived in a farm labor camp, so I was in isolation for a good year in Santa Rosa, and then went on to college and so on. And so I grew up as a farm worker, and I established these efforts to build this radio station because of what we're talking about is lack of communication or misunderstandings and all that. So taking from the conversation today, I think that one of the things I would like to comment on is, again, said by a prior participant and presenter, was that we should not underestimate the anti-immigrant sentiments and the forces that these forces should not be underestimated. I think that we should help immigrants build our own institutions. I think that's something that I know Tony works for a foundation, but I don't think you need to be part of a foundation in order to support those efforts, at least morally or whatever perspective. I think that's so important. And also to support authentic community media opportunities. I think we should be able to turn over the microphones and cameras and keyboards to immigrants and to youth. I think that would be very helpful. Build capacity to, by the way, that's something that the endowment supports. We should be building capacity to address the integration of immigrants through local and regional collaboratives of service providers, immigrant advocates, and legal services, and that's something that the endowment and others are doing, including in the community where I live now in Central Valley and Fresno. Assist the building of a positive culture within the immigrant community that includes a positive culture on health, around oral health, for example, or managing diabetes, and those are just some of the examples that have already been presented here. Positive culture drawn from the positive elements of the immigrant traditional cultures, like in terms of Latinos. We have a campaign around La Cultura Cura, which is around how to take some of the positive elements of traditional cultures to build a positive culture, including our diet. And also supporting traditional arts and immigrant native languages. That's so important for the mental health of the immigrants individually, and families and communities. I think we need to build effective channels of input and feedback for services by institutions serving immigrants, like the case of Cambridge that was pointed out earlier. I think we should advocate for the establishment of immigrant officers at our communities, whether it be a small town or a city. That should really, really help and address some of the coordination efforts and communications. I think multilingualism in our schools, that's so important, K through university, and also multilingualism among our professions. That would help a lot in communication. Again, around what Tony has been talking about in the endowment is work around policy and advocacy for healthy communities, as Tony has described. And then look for trusted immigrant messengers within our immigrant communities. Especially, I think that's critical among any community, but we should be looking at communities with low literacy, and we should not be judging the trustworthiness or the leadership of some of these folks, even though their formal education may be very low. They may be illiterate, but they may be the most trusted person or leader in their community. So anyway, those are just some of the thoughts that I have. And I'm really impressed, by the way, and honored to be part of this. And I've learned a lot. I took a lot of notes.
Mr. John, some of your ideas about what changes are needed?
Sure. Yeah, I should also mention that this has been a very interesting discussion today because it's been nice to hear the perspectives of different people, coming at this important topic. I'll say a little bit more about the health forum's work. So I think, in terms of what changes are needed, I mean, I'm going to go back to the community-based organization. So when I talk about the CBOs that we work with, these aren't community health centers. These are smaller community-based organizations that provide a variety of different types of services to the Asian Pacific Islander population across the country. So, earlier somebody mentioned Arkansas and the Marshallese population that's there. We work with organizations that serve these smaller emerging communities. We work with an organization that helps the Tongan population in Salt Lake City, Utah. So organizations all over the country that are providing services like job placement or help with small business, financial literacy, these type of other services, not just healthcare services. So, and then in the context of, I don't know if some of you remember Jeff Caballero's presentation this morning. He was talking about the Action for Health Justice Network, which the Health Forum was one of the leaders in creating that. And again, to repeat, that was a collaborative of about 70 different organizations, both community health centers, but also these other community-based organizations in 22 states across the country that was created. We created this network in order to make sure that Asian American, Pacific Islander, Native Hawaiian individuals were able to enroll in coverage through the Affordable Care Act. And again, the focus was on limited English proficient and immigrant individuals. And through that experience, we really saw how the in-person assistance from these community-based organizations was key to helping people enroll in coverage. And we've heard about some of the different strategies throughout the day, like, for example, working with faith-based organizations, working with small businesses where we say this phrase, where people live, work, play, and pray, right? So going to the organizations that are really the trusted sources of information in the community and having them be involved in helping people enroll in coverage. That was so important in the efforts that happened over the last 4 years. And as Jeff also mentioned, the challenge was there's not always support for these organizations. So the Navigator grants that came from the federal government, most of these organizations didn't get money, to do the work. They did their outreach work because they knew that was needed for the community. If they weren't going to do it, people weren't going to enroll in coverage. So I think as we move forward, we really have to think about how we can support these organizations, how we can partner, not just, partner in terms of helping, but financial support, So, one of the things that we try to provide are grant writing trainings for these organizations to help them build their capacity and grow. One of the things that Jeff also mentioned earlier was this development of a health insurance glossary that we created of about 100 health insurance terms in about 9 different Asian and Pacific Islander languages. There was no money for that. People did this they did this as part of something that was needed. There was a very intensive community review process where, how do you translate terms like deductible and things like that, in different languages. So, and the community review process was so important in making sure that these glossaries that we created were user-friendly, were things that people could understand. So I think we have to think about ways, whether it's new ways to integrate CBOs into the healthcare delivery system. Are there new ways that there can be revenue that can go to CBOs to provide these type of services? I think those are some of the things that we need to think about moving forward.
Thank you. I was just sitting here thinking that just hearing these perspectives and these projects is so inspiring, and it's so encouraging to be a part of all of this conversation today. And I want to thank you for having me. I'm going to run out at the end, so if anyone wants to reach me, please contact me later. I'm going to go run and catch a plane as soon as we end here. But so I said earlier that I thought the first step is going to be awareness raising. But of course, there's obviously a lot more to that, and that's a step along the pathway to really changing behavior widespread. right? Changing the way health information is presented and shared and made actionable by people. So unfortunately, the research evidence is really bleak in terms of our ability to change people's behavior once they're out into practice. Once they're out doing their work, we really have very little way of adjusting people's behaviors, at least in terms of this perspective of kind of clear communication, language services, and lowering barriers to understanding. So, so at Oregon Health and Science University, where I am, we have done a series of studies trying to figure out how do we teach our young learners, our medical students specifically, who I'm working with, and our medical residents, how do we teach them to be the change when they get out into practice, to do the right thing, right? The things that we all know about, all the best practices that we've heard about today and in the past, and everyone in this room knows about, but the majority of people who are out in practice right now don't do. How do we get our people to do that? And unfortunately, our studies we've kind of had a series of negative results where we've done trainings in different ways, try to figure out how do we change behavior, and we can certainly change attitudes, and we can certainly change awareness and knowledge, but it's pretty difficult to get learners to do something different than what they see all around them. So when they get out into their practice and they see their preceptors and their faculty who are not doing that stuff, that's who they want to emulate, right? These are all good people doing great work, and that's who our learners want to be like, and they quickly fall into those patterns. They don't do the things that we teach them. So that's a long preamble to what we're doing right now, which is we've sort of given up on trying to change our faculty because we think that that's a low yield proposition at a giant institution. So I'm kind of taking a more kind of guerrilla approach, or a grassroots approach maybe is more politically appropriate, and saying, look, I'm going to train these students in a new model, and I'm going to let them be the agents of change, and they're going to pull the system along with them as they go. So quickly, I'll just give you some examples of what we're doing here. I'm trying to teach our students right now essentially a set of four core habits that they will do and demonstrate consistently even when they think that no one's looking. And those include, the first one being building a relationship. And these are things we all know about. These are the things like, sitting down, speaking slowly, making eye contact that matches that of the person in front of you. But it's some other things too, like getting the computer out of the way when you come into the exam room and spending some time with the person without taking notes and engaging people. It's that trust building, that early on thing. And it doesn't take very much. We're teaching our students that 30 seconds of time, of undivided attention, sets up a successful visit, whereas you can very quickly torpedo a visit by going straight to the computer and logging in and starting to take notes. So that's the first one. The second habit that we're trying to teach is agenda setting. And that really, I think, is a key one for a lot of the information we've been talking about today. Studies show that, you may know this already, that about 50% of the time, the average patient walking into a primary care office will not mention their main concern first. 50% of the time, they'll mention something else. My toe hurts. Oh, okay. Well, so the unskilled clinician will dive into the toe pain, get through the visit, think they've got a great plan, and as they're trying to leave the hand on the door, the person will say, also, I have chest pain when I go upstairs. Right? So now, if it's a mental health concern, anxiety or depression, 70% of the time, the average patient won't mention that first. So we're really drilling in this skill, this habit of spending as much time as you need at the beginning of the visit to figure out what the person actually is concerned about. The third thing that we're trying to instill from the very beginning is the use of plain language. And this is a fascinating area that I wish we could spend a lot of time talking about. But I was speaking with Dr. Santos earlier after her presentation, which I loved, that trans language notion. And this concept that we've got these medical students who come in day one not knowing anything and have to learn a new language that we call medicalese over the course of 4 years of medical school and then however many years of residency afterwards, where they're learning to use this language they're not familiar with. At the same time, I'm telling them they have to be able to use plain language with their patients. But some of my colleagues are getting upset with them when they start to use plain language. So they've got this terrible tension that they're trying to deal with. They're trying to navigate two languages at the same time, and they're not doing a great job, right? So stay tuned to that one, because this is a kind of an emerging area of inquiry that I think we'll find very useful. And then the fourth one is checking for understanding, and this notion of a teach back, and the fact that what we think is good communication often isn't, and how do you know? So these 4 core habits is going to be our attempt at changing the system from the learner up, and we'll hope that we can now ask our faculty who don't do these things, who don't know about them and don't know how to do them necessarily, or at least don't do them consistently. We'll ask them to now evaluate our learners, and we hope that we can change the whole system by this sort of subversive model.
Can I ask him a question?
Yes.
That's really fascinating. Your faculty is the sort of the resistant part of this equation, it sounds like, or at least the trained physician workforce within your institution. And yet, I would imagine that you correlate this kind of communication that you're training your learners in with higher quality care. Is that true?
I would, yes.
I'm assuming there's some evidence of that. And so my question is, if the communication approach that your attendings and faculty is using doesn't correlate with high quality outcomes, should they not be held accountable through some mechanism for that lower quality interaction?
Well, this is a very good question. Yes, I mean, I would say that part of the reason why the U.S. health, quote, system gets the results it gets is because it's not doing those things, correct? I mean, so I think that the vision, I think, of course, is that if everybody who worked in healthcare presented information that was understandable and actionable the first time, we'd have a much higher quality outcomes across the board. I don't think there's anything special about our faculty at OHSU that's any different. I think they're awesome, in fact. They're great. They provide great clinical services that are on par with everybody else in the country, I believe. But that problem is that everybody else in the country is doing the same thing. Right? So I'm not going to say anything. I'm not saying anything bad about any particular institution. I think they're all the same.
Okay, I'll have to take that.
In each of your areas, you've talked about some potential changes that you'd like to see. So to make those changes, who should be involved? Who should be at the table? And what do we do to entice those folks to be at the table?
Okay, well, I think it's not going to be any surprise that, I'm going to say that there's a power dynamic in these interactions between institutions and people. And if you want to change the outcome, you've got to change the power dynamic, which is why I focus a lot on accountability. That, I went to Johns Hopkins Medical School and trained at Yale and Cornell, New York Hospital, and experienced very much what you're describing. And that status quo is, to my mind, the product of a power dynamic that needs to be disrupted. And the way that you disrupt that is that you develop meaningful incentives and meaningful accountability measures. And so, in our work in community, where institutions don't behave in a way that actually supports a community's health, we create the power of that community to challenge that institution and to hold it accountable. Because fundamentally, we don't believe that it will change on its own. It won't. It's too comfortable. And so that's my simple answer, is develop incentives, meaningful incentives for institutions to behave in a way that correlates with higher quality outcomes. and accountability mechanisms to essentially hold these institutions' feet to the fire, which may be things like ranking, your professors. I'm not just. I know your institution is no better, no worse than any other, as you said. But ranking. They have these. What are the Press-Ganey? Kind of.
Students have them as well.
Right, and collecting that data and using it in some mechanism to sort of rank the quality of the various professionals, or even create incentives. They can't get into a bonus pool unless they meet a certain threshold in terms of their communication skills. I don't know, but some meaningful accountability mechanism, and it's the same thing for us in the community.
We talked about different kinds of changes that were needed, and so this question is, who needs to be at the table to make the type of changes that you mentioned, and how do we get those people at the table?
Well, I can go into some of what Tony was saying. You need to include the client base. I mean, it's essentially, in this case, immigrants and refugees. We're talking about that. So I think they need to be part of that. And when I talked about my suggestions about, for example, building these collaboratives, we are doing it. I mean, it's not something that, is theoretical or I read about it, but actually we're doing it in Fresno. And because we need to build this capacity, because there's it's just not enough resources to serve immigrants and refugees. And so we need to be able to build the capacity locally in as many communities as we can to try to at least address the needs of some. And hopefully it'll be a better. And then I also think that that those institutions that serve immigrants, as many as some of the key folks that maybe, how would I say, be most friendly to collaboration should be there, because not everybody wants to. For example, in Fresno, the bishop, Catholic bishop, was invited to our collaborative this 4 years ago. He never showed up or sent anybody. Now he has, by the way, a couple of weeks ago, he decided to join. But I think there are some people you want there, but are reluctant. So instead, who do you have there? Well, a lot of some of the larger social services providers, for example, immigrant attorneys, for example, immigration attorneys, community organizers, school districts, adult education people. I mean, those are the ones that are at least are in our collaborative. And so, I'm so glad that the people from the, adult education got we heard from their perspective, because they're so important to all that we do, and they're very critical in our collaborative in Fresno.
Mr. John, who needs to be there? How do we get them there?
Well, I think so. I talked about this, and we've talked about this throughout the day, but this concept of building trust with community-based organizations and providers. And so I'm thinking, we look at this, overall we're going to look at this through the lens of cost. How can we save, what are the cost savings? So I'm thinking that health economists need to be involved in looking at models, that can be utilized to say, better integrate community-based organizations into a healthcare system. So what is the cost savings? We know that we can get better culturally and linguistically appropriate care when we maybe involve CBOs in helping, limited English proficient and immigrants navigate the healthcare system. But what does that mean in terms of cost savings? And if we can show that evidence, then would insurers and others be more willing to kind of engage in these partnerships? So I think that's something that needs to be explored a little more. The research and from the research perspective, the health economists, and really show how cost savings may be achieved.
Can I try? Thanks. Okay, so yes, incentives are the way to do this, and what those look like is is going to be the big question. I think, so for those people out in practice, I think there is evidence that we can incentivize, quotes, good behavior. The Joint Commission is one example of an influential body that has created change where change was difficult to create, and through incentive programs, right? Nobody likes it when the Joint Commission is going to show up and they all get their act in gear and things happen. So that's one place, and I think the Joint Commission could do a good job of, for example, holding institutions to the class standards, culturally and linguistically appropriate services. There's an area there for improvement there, I think. In terms of our educating our health professions who are learning, the certifying organizations like USMLE and other certifying organizations can incorporate this kind of material and standards into their testing and certifying programs. I think there's a lot of room for that, and I think there's some interest in that area, but there's a lot of competing demands.
Okay, thanks. One last question for those who wish to comment. You've talked about some of the changes. What types of resources do we need to make these changes? People want to comment on resources? And
I'm going to pass this along.
yeah, you don't have to. It's not going to be the California endowment funding everything.
$1 billion over 10 years.
I would, I mean, you know, the easiest answer is money, but I think will maybe is a more important one, perhaps. And I think I'll loop all the way back to my first comments, which is about awareness raising. And I think that there's a lot of good work going on. Obviously, this room being a small sampling, and I think the more organizations and the more individuals understand the importance of these issues, the will is there, and perhaps health literacy as a tool is a mechanism for achieving a lot of goals that a lot of people out there aren't aware of yet. I think I described this in a conference earlier last week as I think of health literacy as in two ways. One is I think of it like a handle that fits on any machine, and if whatever your problem is that you want to fix, you can take health literacy and apply it to that issue, and you can generate improvements that way. Or the other way I described it was as a Leatherman tool. I don't know if that's a West Coast thing or not, but you know what that is?
No.
A Leatherman tool is amazing. It's like the Swiss Army knife on steroids. It's like got everything all in one. And I think of like health literacy is kind of like that. It's like a universal tool in many ways. But I don't think a lot of people realize that or think about it that way or know about it or know enough about it to use it. So again, I'll go back to that awareness thing.
Okay, I agree that it's a lot of it is about will. I mean, and I'm not going to go into the numbers. I know a lot has, from my vantage point, a lot has to do with education and what kind of education we provide to our citizens. And I know there's a dollar amount that's been passed around here in California anyway, to provide everybody here in California a free college education, which is about $2 billion a year. So that's a figure. And that's just one element, but I think when we talk about bilingualism, when we talk about creating a workforce that understands and can better communicate, you got to think about these kind of investments, and will definitely is part of it. But there's a lot of other things that come with it that are simply how would I say, having the will, changing the will, and having folks do what they should be doing, like the faculty. I mean, it's a mindset, right? And it's not just the medical faculty, by the way. I mean, I'm a CSU trustee, California State University system. We have 500,000 students, including, we graduate about over half of the teachers here in California. And so, there's a lot could be done. We have a shortage of bilingual instructors, for example. I mean, it's pretty relevant to this conversation, and so on and so on, so forth. So I think a lot of, and by the way, as a trustee, I see that a big obstacle, frankly, to diversity is the faculty. you know, it's just hard to change. But you know, I mean, we have a very progressive board right now, a board of trustees, but it's the faculty, and it's just a big. So it's not just the medical schools.